A very good evening, everyone. This is Dr. Tramberg from Zydus Vaccines. I am the medical advisor for Zydus Vaccines. I extend a warm welcome to all of you from Zydus Life Sciences. So, thank you all for being here today. I want to begin by acknowledging the strength and resilience of our patients and the unwavering dedication of our healthcare team, especially our healthcare professionals. It's a privilege to come together in support of something that, while simple, has a profound impact on the health and safety of our community, a topic very important to all of us, the influenza vaccination in oncology. For patients undergoing cancer treatment, the immune system is, of course, compromised, making even a common flu virus a very serious threat. That's why influenza vaccination is not just recommended, it is a vital part of supportive cancer care. We want to learn more on that, and for that, we have our renowned speaker, Dr. Palanki Satya Dattatreya, with us, who is the Chief Medical Oncology, Renova Soumya Cancer Center, Hyderabad, who was a past chair 2015-16 of the IEP Pediatric Hematology and Oncology chapter, has various research contributions, published studies on pediatric oncology, lymphoma treatments, and leukemia protocols, and has made quite a number of international presentations across ESMO, SARC Oncology, FOCON, and so on, and has many other accolades to his name. So over to you, Dr. Palanki Satya. Let's have a good learning. Thank you so much.
Thank you so much, Trayambak Dattaji, for a very nice introduction. And more than that, the context was set with regard to influenza vaccination in oncology. I think that's a very important burning topic, which is not commonly discussed. No. Please go back. We'll go one by one. Which is not commonly discussed with the patients. And also, we need to clearly understand the importance of influenza vaccination. Next. So let me start with the introduction as to influenza every season affects almost every country, in the country, every community. And so consequently, a large number of individuals worldwide get afflicted with this virus. Next, each year, 1 billion people are affected. No, we'll go one by one. When I say each year, 1 billion people are affected by influenza. More importantly, it's not like a common cold. And we end up with a high rate of hospitalization. So this virus spreads the way a rhinovirus causing common cold will. But unlike a common cold, a substantial proportion of patients end up getting hospitalized when afflicted with the influenza virus. So much so that we could have deaths also next. And that's why the respiratory disease caused by the influenza virus can cause between 3 to 6.5 lakh deaths. Now, that's very important because these can be preventable deaths if vaccination is advocated by the healthcare professionals to our patients and also to our colleagues. Next, now the adult or the elderly cancer patient would of course be having the same comorbid conditions as general population of that particular age would be, but he already has one immunocompromised condition, which is a malignancy or a neoplasm. And on top of that, the treatment for that malignancy or that neoplastic pathology further causes even more immunosuppression. And with that, the patient now already has two additional comorbid conditions to bring down the immune system. And that's why these patients are even more prone to get the seasonal influenza. If you look at the age more than 65 and age more than 75 years, next slide. Age 65 years or more than 20% of the population would be having at least two comorbid conditions, in addition to being an elderly cancer patient. And if the age is 75 years or more, then more than 50% of this population would be having at least two other comorbid conditions, strongly predisposing almost half the population who are more than 75 years of age to a virus which spreads easily but can cause life-threatening respiratory disease complications. So with that introduction, having understood that we are dealing with a virus which can spread very fast like a common cold would, but not get relieved so easily and actually end up in causing complications. Let's now talk about next influenza vaccination in oncology, and patients with malignancies are at increased risk of getting infected with the virus, and more than that, serious influenza related complications. Next, and that leads to higher rates of hospitalization and mortality in otherwise healthy cohorts. So patients' malignancies have an added risk of getting the infection, and more than that, a further heightened risk of getting hospitalized because of the complications. Now, let us try to look at an example of the 2009-2010 influenza pandemic, where several studies, next slide, and these studies all looked at oncology patients only. And we found there were high rates of hospitalizations, viral pneumonia with the influenza virus itself. On top of that, superimposed secondary infections by bacteria or fungi, and that caused death in 9.5% of patients. And this is not just one study, but several studies in that pandemic, which we all remember, which was in the year 2009 to 2010. Now, as far as the recommendations are concerned, based on all these high rates of hospitalizations, high rates of influenza complications, and pneumonias, and even mortality, recommendations and guidelines across the world therefore talk about annual vaccination against the influenza virus. Next, but vaccination rates among cancer patients are apparently low. So that becomes a paradox. On one hand, we know that we have these patients who have very high chance of getting these infections. On the other hand, though we have a vaccine available and as part of guidelines and recommendations, the vaccine rates seem to be really low. In fact, next slide, few patients with diagnosis of malignancy are advised about influenza vaccination by oncologists. And that's because maybe they're so focused on the oncology malignancy disease itself or the treatment itself, that in that bargain, we try end up not remembering that influenza vaccination, which otherwise would be told to any adult of that age, is unfortunately being forgotten by many oncology colleagues. And so we are talking about next immunocompromised patients, which is what oncology patients are, and the influenza vaccination. And so these patients could be on various drugs. And that's why it's important to know also as to which are the conditions where the vaccine should be administered at the right time. Say, for instance, we have patients of hematolymphoid malignancies, lymphomas, especially lymphomas where we require to give these patients anti-B cell antibodies. For example, drugs like rituximab or alemtuzumab are anti-B cell antibodies. Next, now patients who are on regimens which incorporate these anti-B cell antibodies, they become further immunosuppressed because the B lymphocytes are being depleted by drugs like rituximab, alemtuzumab. And then, when a vaccination is done, they will not be able to mount an effective vaccine response, an immune response. And so, vaccination doesn't make sense in patients who are on the anti B cell antibody regimens because the vaccination is done since an immune response is not mounted. We falsely believe that the vaccination has been done to realize that that was essentially water given to the patient because no purpose is served. So, routine vaccinations in patients who are on anti B cell or anti lymphoma antibody should be postponed for 6 months from the day of the last administration of, say, rituximab or alemtuzumab. So, it also becomes very important that not just advising about the vaccination, but also trying to find out what treatment, what malignancy the patient has. And if the treatment involves anti-B cell antibodies, then we need to wait for 6 months before we put these patients and advise them or advocate them influenza vaccination. Various biologic agents, targeted therapies, and even the new age immuno-oncology molecules. Next slide, cause various immunomodulatory and immunosuppressive effects. And so these targeted therapies, immunotherapies, they change the milieu of the immune system in the body so much so that we might have to rethink and have a proper guidance of when to use influenza vaccination. And there are various factors which can affect the degree and the extent of immunosuppression, immunodepression, immunoincompetence, and immunomodulation by all these new treatments, which are very effective against the disease malignancy per se, but also the microenvironment in the body, which can trigger the immune response to vaccination, also takes a beating. And so, next, the factors which can affect the degree and extent of immunosuppression can be the individual drug, the dose, and the therapeutic context of administration. Is it palliative intent? Is it curative intent? Is it anti-B cell antibody? Is it rituximab? Is it bortezomib? Or is it a drug like pembrolizumab or nivolumab as a immune checkpoint blockade therapy? In addition to that, we all know that spleen becomes an important organ when it comes to mounting the immune response, and some of the cancer patients or survivors might be having anatomical asplenia. The splenectomy was done with an intent to treat the patient's malignancy. And sometimes we could have a functional asplenia, which means that the spleen has been rendered dysfunctional or afunctional, and so it becomes functional asplenia, and that is causing the immune deficit. So, next slide. Some cancer patients or survivors may have asplenia, and therefore they may be able to receive live vaccines but attenuated because they are not highly immunocompromised when compared to the patients who are getting the anti-B cell antibodies, because they'll be able to surmount an immune response. So the right context and setting of that particular patient who is given a vaccine schedule becomes so important. In fact, when we plan splenectomy, we make sure that the vaccinations are done much in advance before a spleen removal is planned by the treating oncology or the gastroenterology team. And so comes the question, which cancer patients are considered highly immunocompromised? Next, and so we'll try to look at those three patient populations which are regarded as highly immunocompromised. Number one, next, patients who are receiving chemotherapy either concurrently or sequentially or along with radiation therapy in the last 3 months. So once it comes to a patient who is on chemotherapy or radiation therapy or both, either sequential or concurrently, and at least 3 months should have passed. Because in those 3 months after the chemo radiation, the body's immune system is compromised. And therefore, these are patients who are highly immunocompromised. Giving vaccination at this time would be inappropriate. Now, some patients have advanced metastatic, disseminated, or generalized malignancy. Next, so patients having a hematologic malignancy or generalized malignancies are again highly immunocompromised. And some of my patients would be getting prednisolone or they might be transplant candidates. Next slide. So patients who receive 20 mg of prednisone daily for 2 weeks or more again become highly immunocompromised, and patients undergo a stem cell transplant. So if a stem cell transplant has been done, then we need to wait for not 3 months, not 6 months, but 2 years before a vaccination can be advocated. And if the patient has ongoing signs of GVHD, graft versus host disease, then we need to wait till that thing gets solved. And sometimes that can go beyond 2 years. So all these recommendations of the definitions of patients who will be considered highly immunocompromised for vaccinations are from the 2018 publication by M.K. Shah et al. It's so important, therefore, to make sure we place our patients in any of these buckets and make sure that we label them as highly immunocompromised and so decide on influenza vaccination in these immunosuppressed adults. So if this was one publication, we spoke about these patients who are highly immunocompromised. Next slide. It's about a Cochrane review by Bitterman et al., which looked at a review article, and this Cochrane review tells us, next slide, that there is lower mortality and lower infection-related outcomes in patients who get the influenza vaccination done. And so this Cochrane review clearly supported the benefit of vaccination in adult cancer patients and elderly cancer patients. But beyond this, we have a lot of observational data also, including what we see in real life, in the real world. Next slide. So these observational data suggest lower mortality and lower infection-related outcomes when influenza vaccination is done. Next, and therefore, the benefits far outweigh the potential risks with influenza vaccination when we vaccinate adults. So I think this slide clearly tells us about not only a Cochrane review, but also observational data from real world studies. And the bottom line is the benefits of influenza vaccination far outweigh the potential risks when you vaccinate adults with cancer against influenza. And as oncology colleagues, we all believe about and we all routinely follow some guidelines. Most widely followed is the National Comprehensive Cancer Network or the NCCN Clinical Practice Guidelines. Next slide. We'll therefore talk about the NCCN clinical practice guidelines. Next, and what do the guidelines tell? Yearly annual influenza vaccination is suggested for all cancer and transplant survivors. But then which vaccination should we do? Should it be a live vaccine or an inactivated vaccine or a recombinant vaccine? The NCCN guidelines clearly tell us that the preferred vaccines are next, inactivated influenza vaccine or recombinant influenza vaccine. And the inactivated vaccines can be of three types: trivalent standard dose, trivalent high dose, quadrivalent standard dose, which is respectively IIV3, IIV3 high dose, and IIV4 standard dose. And then you could have the recombinant vaccines, which are trivalent or quadrivalent. So RIV3 and RIV4. The R standing for recombinant, and previously the I standing for inactivated. So we need to use inactivated influenza vaccines or recombinant influenza vaccines. And of all the different types of vaccines I discussed, no studies have shown that one vaccine is superior to the other in the cancer survivor population. Next, and that's what my next sentence is. Therefore, the preferred vaccines can be influenza vaccines inactivated or recombinant, and all of them seem to be equally good and similar in outcome. Let me now draw out a page from the NCCN guidelines, next slide, where they talk about influenza vaccination. Patients with hematologic or solid tumor malignancies. So liquid malignancies or solid malignancies all should receive inactivated or recombinant influenza vaccine annually. Clear and loud message when it comes to prevention of cancer-related infections. So I think there's no reason why our patients should be deprived of the benefit from getting the vaccine shot against influenza, because it has so many advantages and essentially nil or negligible or minimal disadvantage. Now, with that, let us now look at the pediatric population, especially after they undergo hematopoietic stem cell transplant. Next, so let's talk about immunization in the pediatric patients after hematopoietic stem cell transplantation. So next, we need, next please, these recipients should be immunized against a number of pathogens when they are likely to mount an immune response. There's no point of giving the vaccination if the immune system is so depressed that it cannot surmount an immune response against the vaccine we gave. In fact, during the first 24 months following a hematopoietic stem cell transplant, we should completely avoid, next slide, we should completely avoid live virus vaccines. So when can we give live vaccines? 24 months following a transplant in patients. Next slide. So live vaccines are indicated 24 months following a hematopoietic stem cell transplant, and this patient should not be having an active GVHD or should not be receiving an immunosuppressive agent. So I think the guidelines are very clear about influenza vaccination in HCT recipients. Next. Taking this further, next, vaccination against influenza remains the primary method for preventing influenza. I repeat, influenza vaccination remains the primary method for preventing influenza. And these patients should get annual administration of the inactivated formulation of the influenza vaccine. Next slide. And this administration should be lifelong for all hematopoietic stem cell transplant candidates and recipients who are 6 months of age and above. So essentially the entire pediatric population 6 months of age and above should get lifelong annual administration of the inactivated influenza vaccine after a stem cell transplant for whichever indication might have been performed. Next, vaccination should be given beginning 6 months following transplantation. But if there is a community influenza outbreak, then you might want to give it after 4 months and not wait till 6 months, because by that time, in those 8 weeks, the outbreak would actually spread and cause misery to the child who had a recent hematopoietic stem cell transplantation. For some reason, for these patients, if the vaccination happens within 6 months following transplantation, once the outbreak gets over, a second dose should be considered. Next, and so it's so important to understand that sometimes you might want to give a second dose not the next year, but much before the next year if the vaccination happens within 6 months following a transplant in the hematopoietic cell transplantation recipients. Let's continue this next. To understand, next, that individuals less than 9 years of age, next, who have not previously received the influenza vaccine should receive 2 doses of the influenza vaccine 1 month apart. And that's when we are trying to give these patients, for some reason, the dose is within 6 months from the transplant. Now, what type of vaccine should not be given to the hematopoietic stem cell transplant recipients? There is an intranasal formulation also. Next slide. So, though it is live attenuated, the intranasal formulation should not be given to the hematopoietic stem cell transplant recipients. In fact, since the pediatric patients who are prone to catch the infection very commonly and easily, there are some adjunctive strategies also. How to protect the HCT recipients? Adjunctive strategies beyond the vaccines are none. Next slide. One, immunizing the close contacts, immunizing the hospital staff, and also use chemoprophylaxis in some cases. So these are adjunctive strategies to protect the hematopoietic stem cell transplant recipients from the influenza virus, which can sometimes have life-threatening complications. So, what is the incidence of these complications when we talk about life-threatening influenza A, influenza B infections? Next, so influenza A and B infections can be life-threatening in hematopoietic stem cell transplant recipients. Next, 5 to 6% of patients who got a hematopoietic stem cell transplant get admitted with respiratory illness, and they had influenza and now superimposed infection with a bacteria or a fungi. In more than 50% of these patients, the URTI will progress to a pneumonia, which will be an invasive influenza, a viral pneumonia, or a secondary bacterial or fungal pneumonia. And once that happens, then the mortality is 50%. So 5 to 6% of patients would go on to require hospitalization. In more than 50% of these 5 to 6%, the URTI will progress to a life-threatening pneumonia, causing a 50% mortality. Now, that itself tells us that once the mortality is 50%, and if it's preventable, then I think we need to dwell on this topic of HCT recipients getting the vaccination very seriously and start applying it in clinical practice the day we learn about this. And we keep on disseminating the information to make sure we don't miss these vaccinations. Now, the antibody titers against the vaccine will be lower after hematopoietic stem cell transplant, especially in the first 6 months. Next slide. In patients with GVHD2, we might find lower titers, but still some protection can be elicited. And so, therefore, some protection can happen. It's so important to make sure that if a influenza outbreak happens in the community, even though 6 months have not passed, the vaccine shot can be given. There was this study which looked at 136 allogenic HCT recipients. Next slide. Trivalent influenza vaccination reduced the prevalence of influenza was lower, the progression to LRTI was lower, and the hospitalization was much less when compared to standard dose trivalent vaccination. This high dose vaccine gave higher protective antibody titers and was well tolerated. At the most, a slightly higher number of patients had some injection site reactions, which were mostly mild and resolved. To repeat, influenza infection, the prevalence was lower, the progression to LRTI was slower. Getting inpatient admission for some complication was much less. And that's why the high dose vaccine, which is eliciting more higher protective antibody titers, is what is followed by some institutions and authorities in their patients of hematopoietic cell transplant recipient. So we'll again talk about the timing of the vaccine administration. Next slide. And does this timing predict the response? There was this study in BMT journal in 1993. Next slide, where the response rate to the influenza vaccine after transplant was zero if given in the first 6 months after transplant. The response rate was 25% between month 6 and 24, and more than 60% after month 24. And that's why we say we can wait for 24 months and then give the vaccination. But a publication after 15 years in transplantation in 2008, next slide, showed that vaccination at least 6 months after transplant at 80% effect in preventing influenza, and that you could find influenza specific T cell responses, though they might be attenuated or lesser in response, but they modify the course of the infection, even when given 3 to 6 months after transplant. Therefore, whenever suspicion is there, these patients should get the benefit of the influenza vaccination. So again, since we have discussed the background about the influenza vaccination, the influenza infection and the complications thereof, and specific populations and how vaccine administration timing should be scheduled, now let's look at next the recommendations. And so, next please, we'll talk about the NCCN guideline and the ASCO guidelines. Next. So this is the table talking about the recommended vaccine schedule after autologous or allogenic hematopoietic cell transplantation. Influenza injectable recommended timing after an HCT is 4 to 6 months. The number of doses is 1 dose and it's an annual vaccination. And this should be continued lifelong. This is what we discussed. Next, let's now talk about the ASCO guidelines. And there are 4 important take-home messages from the ASCO guidelines. Next, vaccination annually with the influenza vaccine is recommended for all adults with cancer. It reduces the risk of influenza-related vaccinations, complications. It reduces the risk of influenza-related complications. But then, what about the safety and efficacy? Next, these vaccines are generally safe even for patients with cancer. Studies have shown that even though the immune response may be lower in these patients, it still provides significant clinical protection. There are some special considerations as I discussed, for example, for the hematopoietic stem cell transplant recipients. Next, so for these patients, influenza vaccination is recommended starting 3 to 6 months post-transplant, especially during periods of high community transmission. High-dose influenza vaccines are preferred for these patients. This is what I alluded to earlier. High-dose influenza vaccines are preferred for these patients. At the most, they may have more slightly higher chance of getting a injection site reactions, but they are able to give more higher protective antibody titers, and therefore the high dose influenza vaccines. And finally, in the ASCO guidelines, the fourth is next the impact on the outcomes. It improves infection related outcomes. It reduces the incidence of pneumonia and the need for inpatient hospitalizations. Next, even WHO and the US CDC for prevention also talks about recommending influenza vaccination in routine clinical oncology practice. Next, we'll now talk about the strains of the influenza vaccine. Next, and Zydus was the first to launch the latest strains third year in a row. And these are the strains of influenza A and influenza B. And so it's so important to study the community and bring out the vaccination which will be more suitable to that particular region or locality or country, so that we'll be able to look at the antigen drift and shift and modify the vaccines accordingly. Coming to next, what has been India's flu protection with regard to Zydus dedicating itself to life? 3 million administered doses every year. Next, so there are 3 million administered doses every year. Mm, This looks like a very big number, but still a lot has to be done, especially for oncology patients. A lot still needs to be done. Next, let's try to now have a small session with regard to some routine questions which should be answered, especially for oncology patients. Next slide. So the question is, when should we vaccinate a patient with solid tumor? Next. In general, inactivated vaccines should be avoided in patients receiving chemotherapy when they are on chemotherapy or other immune suppressive therapy, because then the vaccinations may be less effective. And that's why if vaccines are to be done, in general, all vaccines indicated given to adult cancer patients should be given next before initiation of chemotherapy, or before initiating immunosuppressive drugs, or before radiation, or before splenectomy whenever feasible. Next, inactivated vaccines should be given 2 weeks or more than 2 weeks prior to chemotherapy. If we have that much time, before we wait for some results or some reports to come and the patient is clinically stable, to not initiate an active oncology treatment like chemotherapy, then at least 15 days prior, we need to give these vaccines. If inactivated vaccines are given during chemotherapy, next, then they should not be considered valid doses unless protective antibodies are documented. And so, though I stressed upon the understanding of giving the vaccinations before starting chemotherapy or later, let's now ask one more pertinent question. Next, can oncology patients be immunized during chemotherapy? And I think the answer is a resounding no. Next, patients with leukemia, lymphoma, or other malignancies whose disease is in remission, and if they have not received anti-B cell antibodies, then after 3 months the vaccination can be done. And this is what will also be the case for patients of solid tumors where chemotherapy has been completed for at least 3 months, and then they can receive inactivated vaccines as well as the live virus vaccines. So let me end my talk by the summary slide next to give you on 5 key takeaways. Next, influenza vaccination is effective in reducing illness. It has been shown to reduce the risk of flu illnesses, hospitalizations, and in fact, flu related deaths. Consistently across various studies, this vaccination provides significant protection against severe outcomes. Take home message 2. Next, this vaccine protects against multiple strains because these vaccines are designed to protect against those strains of influenza viruses which indicates will be most common during the upcoming season, and therefore it's called as a seasonal influenza vaccine. What about the safety? And that's the third key takeaway. Next, these vaccines are generally safe. Most side effects are mild, temporary, reversible, and these are like soreness at the injection site, some low grade fever, and muscle aches. Which means, next, serious adverse events are extremely rare, and even the high dose influenza vaccine at the most may cause some higher percentage of injection site reactions. And therefore, influenza vaccines have a tremendous impact on public health. And that's my last takeaway. Next slide. Flu vaccination not only protects that particular person getting the vaccine, but also helps to reduce the spread of influenza in the community, thus contributing to overall public health by lowering the incidence of flu complications and deaths. And with that, I would like to close my talk further reiterating and re-emphasizing the importance of influenza vaccination, the seasonal influenza vaccine to be given annually for patients or all adults with solid tumors or liquid tumors or hematolymphoid malignancies or hematopoietic stem cell transplant recipients. Thank you so much.
Thank you so much, sir, for your insightful session. So we will have a question answer round and then we will have a closing statement for the webinar.
No problem.
So yeah, attendees, the floor is open for question and answer. If anyone have question, you can write it in the chat box, and we will able to see the questions. So we will wait 2 to 3 minutes for the participants
No,
to
no, no.
type.
I completely understand. No problem at all. Because since everything was covered in the presentation, so and since I was reiterating, so probably there'll not be any questions also.
Sir, so regarding that, I had some questions, sir. Like how many doses should we give to the patient, like to the patient who before the this
No,
chemotherapy? Is there any dosage system? Like what should be the doses for the vaccination thing?
no, no, no. It's the standard is annually 1 dose of the influenza vaccine. Don't administer the vaccine during the chemotherapy sessions. Let me give an example to you. Suppose you're a patient of non-small cell lung cancer who is stage 4, has advanced metastatic disease. The biopsy has been done, the PET scan has been done, and we know a biopsy proof that this is stage 4 advanced metastatic non-small cell lung cancer adenocarcinoma. Now the paraffin block will be sent for the molecular testing to find out if there are some druggable targets or not. The report will take 2 to 3 weeks to come. And if the
Okay.
patient is completely stable and has a good preserved ECOG performance status, then you would not want to start urgently chemotherapy or immunotherapy. So till
Okay.
that time we are waiting for the reports to come, since it will take more than 2 weeks before starting the chemotherapy or target therapy or immunotherapy, the vaccination can be done today. And when the reports come after 2 weeks, then the treatment for the malignancy can be commenced. So prior to initiation of chemotherapy, 2 weeks or more than 2 weeks, the vaccination can be done. Now, second, let us take a patient of breast cancer, second scenario. Now, this patient underwent surgery and then required, say, 8 cycles of chemotherapy or 6 cycles of chemotherapy. So, during the chemotherapy, we should not vaccinate. When the last cycle of chemotherapy gets over, then after 12 weeks, then after 3 months, if no further chemotherapy or chemicals or treatments are planned, except treatment like, say, hormone therapy, which is simple oral pills, then the patient can take the seasonal influenza vaccine. One dose is enough. The third scenario is if a patient has undergone a hematopoietic stem cell transplantation for whichever indication, and after 6 months you would want to start the vaccination. But in the fourth month or in the after 16 weeks, say there's influenza outbreak. So then you can give a vaccination dose, even though 6 months have not passed, and the patient gets the influenza vaccine shot. But if you again want to repeat one more dose and not one dose, you'll be given 2 doses there after 1 month from the
Okay.
first shot. So, three different scenarios I told you the examples to let you know how the vaccination is scheduled. It's one vaccination shot once in a year,
Yeah.
except for those patients where you might want to give 2 shots if the vaccination had to be done within 6 months from the hematopoietic stem cell transplant.
Okay. Got it, sir. Thank you so much, sir. So,
One more
this,
question from audience. Uh, One second, sir. How long does the influenza vaccine last? Can we take the influenza vaccine if the strains are not changing?
Also, by default, these vaccines are prepared in such a way that all the strains have been taken into account. And that's the best part about this vaccination. So you prepare the vaccines depending on the strains. And Zydus was the first to launch the latest strains 3 years in a row. So that's that, and this is called as the antigenic drift. Every year the virus undergoes small mutational changes,
yes, sir.
and that's called as a drift. But then maybe once in a decade or so, there is an antigenic shift where a dramatic change in the genome happens. So then an altogether new vaccine gets launched. So therefore, we take into account the antigen shift and the antigen drift whenever the strains of the influenza vaccine are assessed by the epidemiologists and the vaccine makers, and then the vaccine comes into the market.
Okay, sir.
Okay. Sir, one more question from the audience. What do you recommend, whether SH strain or NH strain? Can you throw light some on SH and NH strains?
On the strains you're talking about?
Yes,
Yes,
sir.
sir.
They are asking about the clarity regarding the southern hemisphere, northern hemisphere strains.
So, as I was talking to you all and trying to explain that the best part would be to look at a, a region specific or a community specific or a nation specific, because you would want to look at the strains in that part of the globe and then vaccinate accordingly. So, from my side, therefore, I think it should be all regional, as I mentioned, that you look at one hemisphere, and then because these strains may change from one place to the other if they're wide apart. with thousands of kilometers apart. So I think it's so important to make sure that we have a leader in vaccine making who would be able to, say for instance, pertain to our country and the epidemiological study all the vaccine strains of influenza and prepare the most effective vaccine to prevent influenza infections. And that's what Zydus is doing.
Yes, yes, sir. Sir, I hope now audience are also clear for the question. Nobody has further questions. So, sir, I will give a closing statement. So, on behalf of Zydus, we thank all the attendants for joining today's webinar on the role of annual influenza vaccination in oncology. So, we extend our heartfelt gratitude to you for sharing your valuable insight on the clinical importance of influenza vaccination in cancer care, which is the utmost fatal disease that a person can get. And sir, in this discussion, how you referred the preventive strategies like annual vaccination can help us to reduce a complication, can help us to support uninterrupted therapy, and can improve outcomes for oncology patients. And also, sir, you also help us to understand the guidelines, and you also emphasize leading guidelines such as NCC and ESCO that advocate that annual influenza vaccination is very important for all the cancer patients, especially the patient who are immunocompromised. So, sir, this evidence help us to include our data from observational study and Cochrane review strongly supports that the safety and efficacy of this approach. So now, as a healthcare professional, we must continue to champion such preventive measure in our practice. And thank you once again for all the participation. And we look forward to your continued engagement in Zydus' future educational initiatives. Thank you so much.
Thank you very much. Good night to all.
Good night, sir. Good night.
Yeah, yeah. Shall I leave?
Yes, sir. You
Yeah.
might.
Thank
Thank
you.
you so much.
Bye-bye. Bye.
Bye
Bye.
bye.